obstetric triage and implementing Muse. Dr. Nuzhat Aziz is going to be with us for this. Dr. Nuzhat, please.
Yes. So over the next 15 minutes that I've been given, okay, I'm going to complete 2 topics. So I'm going to be a little fast, but try to convey to you the major concepts. Now, the obstetric triage is very different because that's an emergency room kind of management, and the other one is an early warning system. So the overview would be, how are you going to do the obstetric triaging in the emergency care services of your hospital, and can morbidity and mortality be predicted by any kind of a warning system that we have? So we are going to go through these, each one. I'm going to finish obstetric triage first. Now, all this time, okay, Fernandez was doing somewhere around 2,500 deliveries. Suddenly, we moved up to 7,000 and 8,000, and we are currently now going up to. And about 4 years ago, we had one patient who was waiting, okay, with abruption, okay, maybe seen about 45 minutes down the line with severe bradycardia when we saw her at the end, and we lost that baby. At that time, the question was, okay, that we have always been operating in this kind of a setup. You know, first come, first serve basis. Whoever comes in, we keep on sorting in a line kind of a thing, and we don't know actually if it's a quiet person sitting the 10th one or the 20th one, we wouldn't know. And at that time, I went to Birmingham because they had a triaging system and got that concept back. So this is the concept where we would ask the person, why have you come? Only one word and triage. So the triage color coding is dependent on the factor that there are some patients that would require an immediate attention from us. They are urgent, they require about within 15 minutes. Okay, somebody needs to see them. There's an expectant one, they do not require anyone to be urgent about it, and then the blue or the black color coded are basically which we can't do anything about it. So in obstetrics, we don't have this 4 category. It is usually used in emergency systems, other places. Now, just a brief idea, the kind of conditions coded color are red are basically those which are very sick, okay, cardiorespiratory distress, eclampsia, active PPH, or a cord prolapse, no fetal movement, diabetic ketoacidosis, and so on. The ones which are yellow are the most of the patients that come into. Okay, the most of the patients that come in an emergency with labor pains, with ruptured membranes, with decreased fetal movements, with hypertension, they all come into this area. Now, conditions coded green are wound infections. They've come for a postnatal visit, booking visit, reports, and so on. So over the past 4 years, I haven't had the need to add in one extra line into this, so it seems to be working well. Now, red, again, has to be seen immediately. It has to be shifted directly to the ICU or HDU. The nurse has the responsibility. She can shift in. None of the doctors are going to shout at her as to why did you shift her to the labor ward. Now, the yellow ones are the ones which should be seen within 30 minutes, okay, and have a review every 15 minutes if the doctor has not been able to come. It will be the responsibility of the nurse to do her vitals check every 15 minutes so that she doesn't become a red patient. Now, the green ones can withstand significant delay, and if nobody has been able to see for 4 hours, then you are supposed to see them every 30 minutes. Now, that is the basic concept of a triage. Can it be done? Yes, it can be done very beautifully. Now, how are you going to place your triage? You don't require a big system. Birmingham definitely was planned for it, and then when we built up a new hospital, we did plan a triage room completely, or a complex. But we did modify. So what did we do? We got a table and a nurse to sit right in front, or a triage manager, we call them, who would ask. So the person walking in would be able to tell what have you come with. And then you come into a room, you've got 3 or 4 beds. One of them would be an emergency bed, a crash cart over there, and from there you will have an NST or an ultrasound. Wherever you want to go, you will go. So not much is really required for the process to be put into place. Now, later on, we moved over to an electronic system wherein it is mandatory for them to move through that without color coding, that they can't go forward. So today I have very good data. It's a very simple one. All you have to do is put a tick for the color or the condition that you are aiming, and move forward and save. The nurse's initial assessment would start, and again, that's very simple. You will just click, 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 and then it will go off. Maybe just 30 seconds of entry it would take, and you will finish it off, and then the doctor sees it. Now, from anywhere in the hospital, I can see how many patients are waiting. I can see how many are red, how many are yellow, and how many are green that are waiting. And if there are too many waiting, I can send another person to tackle or get few of them to the labor ward to have it. And the print comes out after the doctor's review, which is pretty elaborate and complete. And we can discharge them from there, say with a review date, or she either gets admitted to the antenatal ward or to the labor ward. Now, this is the concept of a triage. What you can get at the end of the journey is a report, and look at your report as to where you are going to act onto it, where you have been going wrong. Okay, are you taking a long time? How many reds are you getting? How many referrals are you getting? Do you need to streamline your work? And this seems to be working very well. So the basic concept is keeping a person in front of your emergency room who will ask, why have you come? Okay, very simple. Why have you come? If the person says, I'm bleeding, she delivered and she's bleeding, she immediately is not taken into the triage, but is taken into a different room. Now, moving from here across to the early warning system. Now, what do you understand by the concept early warning system? Okay, the weather department tells you very, very nicely that tomorrow you're going to get a storm and this place has to be vacated. Is there any kind of a tool that we have for obstetrics which would demarcate and tell us that, you know, the healthy mothers are going to go to a complication and then become morbidly sick and then actually will die at some point of time? Can we have any kind of an early warning system? Now, if we take a look at the systems that have been defined, okay, people have been searching for a highly sensitive system, okay, which is capable of predicting. But I think a time has come wherein instead of only predicting, we need to think of systems which will help us avoid the morbidity. Prediction has been studied for a long, long time. And at this point of time, that is in 2016 and 2017, that I have embarked onto a maternal early warning system with a slight difference, that is the trigger tool. Now, there have been a lot of articles which have been done, and this is one article which is extremely good if you want to evaluate all the warning systems that have been put into place. There are a lot of warning systems which are placed in the ICU, and if you take them and apply it to pregnant ladies, they are not good at all. Okay, so 319 chorioamnionitis patients, 5 had sepsis, 1 death. But if you take a look, okay, at the SIRS criteria or the MUSE, they were just not fine. You can't use them because that's a very poor positive predictive value for sickness. Now, in the year 2007, UK-based confidential inquiry made it mandatory for everyone to introduce the early warning chart. Now, the early warning chart aimed to have an identification of these 5 major killers or maternal mortality reasons. Okay, and they said that they put a yellow alert and a red alert. Just to go through, red alert was respiratory rate, oxygen saturations, temperature, BP, systolic as well as diastolic, heart rate, pain score, and a neuro response. This is how they put it out. Now, Fernandez Hospital started the early warning system in the year 2009, and believe me, it never took us anywhere. We evaluated to see did we have an achievement on our maternal morbidity and mortality. It did not. The nurses were not happy, and I'll tell you why it was not very happy. Now, I'm just giving you an example, 140/90, and if you take a look at that, it was a very good, beautiful trend. Okay, yes, it was a very good, beautiful trend, visual trend, where you could put up your data and have a see. She went up, and her BP has been controlled. The main problem with this warning system was the false positive alarms. After some time, the nurse calls up and the doctor says, okay, I'm coming. Half an hour, she goes later. Sometimes she'll say, give her paracetamol. Complaining of headache, hypertension, give her paracetamol. It will be okay. Okay, or you wait for half an hour and then send her back to the labor ward. These are the kind of responses that kept on coming. Okay, desensitization of the team was, I was thinking that how do we, move forward. Now, if you take a look at the maternal early warning trigger tool, which came in 2016, they actually put in the triggers, they lowered down the triggers, like from 90, they made it 85 and so on. They just changed it slightly and then moved forward to give a plan for the doctor to follow. Okay, they had, if you had 2 triggers, you would go to the cardiopulmonary, hypertension, hemorrhage, or the sepsis pathway. If any time you have fever, you will go directly to the sepsis pathway. Now, they also labeled severe triggers, wherein a heart rate of more than 130, respiratory rate of more than 30, SpO2 of less than 90, or the nursing team, okay, gave a huge amount of power to the nursing team, said that anytime you feel that the patient is not doing well, you have the ability to call for help. Now, just to show you, okay, infection pathway, very simple, 2 triggers: notify the physician, test for organ dysfunction. If the heart rate is more, or there is a mean arterial pressure, that is shock is there, then you're going to call it severe sepsis. What are you going to do, and what is it that you're going to start? So the doctors had steps to follow through very nicely, where they could put a tick and move forward and say, okay, this is what we need to do. So the cardiopulmonary pathway, we did not do all these investigations at one go, but we divided them into step 1 and step 2 and moved forward. ECG and an Iccob first step, and then moved over to step 2, and that's how we did. The remaining ones are absolutely fine. They also tell you what is the differential diagnosis, so that you don't have that ability to miss out one of them. Hypertension, they gave endpoints saying within 1 hour you should give 1, 2, 3, 4, so that you have a system in place. Now, hemorrhage is very elaborate. I'm not going to go through in each one of the detail, but then this is a kind of a call out. Okay, did you call for help? Did you increase oxytocin? Did you check her vitals? Did you do a bimanual examination? Did you, or compression? Did you give her utero? So it's a kind of a chart that anybody can take, and the nurse can call out, and the others can follow through. So it was very simple and easy to follow. Now, what they had shown was before application of the early warning chart or the trigger tool, and after, they had significant reduction in the maternal morbidity, composite morbidity, and eclampsia rate. They had reduction in all of them, but not statistically significant. The also good concept was one trigger, they did not take it forward to say that this is an abnormality, but they actually said that if the trigger is sustained over 20 minutes, go ahead and call for a pathway. So we changed the early warning chart the UK had given to put in a purple a column or a purple row, which would tell us that this is a severe trigger. And anytime they scored a severe trigger, the nursing team would have the ability to shift the patient to the HDO or the ICU, whatever they feel, if the doctor is not responding immediately. Now, I'm just going through a case, very simple to say. Okay, we also put the monitoring frequency on top, which was missing in the previous chart. Because if I'm writing hourly, I can go hourly. Fourth hourly, I can change fourth hourly, just to have a very good kind, or every 5 minutes if I want to write. And then moved forward to having another concept like this respiratory rate previously stopped at 30. Okay, but it was not or more. And over here, if you find 30 or more, you are supposed to write the number rather than, like for example, if it is 138, you are going to write 138. It can be a BP of 200 moving down to 180 to moving down to 160. It will all be in the same column. So this was a small change that the nurses had to, because they were writing in some other paper, how do they document moving forward. So if you take a look, the system has remained the same, except that small little changes that we have brought in, and you know, giving a lot of attention to the nursing team. It's always very difficult to ask the doctor's team to follow, but it's very, very easy over 1 month, you know, train the nurses team to follow any kind of a protocol, and they will do it very meticulously. So the entire data collection is done by the nurses team for us. And there was also an issue saying that, you know, how do I know when the patient was shifted? So I said, use one column and write down transfer to so-and-so ward, and start writing your ward a little later, okay, one column later. So this became a very good and an impressive kind of a document, which the nurses found easy to write and document. Intake-output chart is also given a column, so it's easy for them to enter. Now, reports to work on, they give me a monthly kind of a data, which I'm just giving you the Hyderabad or the unit 2 or the high-risk pregnancy unit that we have. So they will give you an idea what were the triggers and what was the incidence of triggers that we have, what were the severe triggers that you have had, and what you can do. So if you find that hypertension is the main cause, then you can take sessions onto them and make the team much better in your response. It also gives you a response time. Now, maternal trigger tool has been 2016 and 2017. Comparison-wise, there have been few parameters which have gone down. I think this will be the year where we would see a change, but then there has been some that has not changed. I haven't put down the incidences because they're very small numbers. Numbers itself, both are 8,000 deliveries in each year, so the numbers itself, there are some which has gone down and there are some which hasn't. So with this, I would like to conclude that the early warning systems are extremely good for creating awareness in the team and for getting the team together, especially the nursing team and the obstetric team to work together. And it seems to be a promising strategy in reduction of maternal morbidity. With that, I would like to thank you once again for this invitation and this opportunity to be a part of this conference. Thank you so much.